We're going to transition to audience Q&A. We invite Dr. Art to join us at the front, and we have our other panelists virtually. So those who are online, if you want to type your questions in the chat box and include the speaker to whom you are directing your question, we'll try to get to as many questions as we can, but of course we have a limited time right here. Thank you. So I'm going to start off with a couple of questions, and the first question I will send to Dr. Ogden. And so, Dr. Ogden, thank you again for joining us and for going through just some of the statistics around that. One of the things and one of the conversations around the utility of BMI really has been of surveillance, particularly at the public health level. When we think about the progress we've made over the last couple of decades in focusing on obesity as a national problem and having support, funding, et cetera, that is linked to the numbers that we say at the beginning of every presentation, right? We say this percentage of the US population is living with obesity, but that largely is based off of BMI. So can you talk a little bit about as we think about expanding our understanding or use or identification of obesity as larger than BMI, how that will impact our ability to accurately survey the country and to identify and quantify the issue?
Well, that's definitely a big challenge because in many cases, like with the behavioral risk factor surveillance system, we use self-reported weight and height. I mean, it's a questionnaire. And so other methods are not available to a system like that, which gives much more granular estimates like by state and by county. You know, at the national level with something like NHANES, we do have DEXA scans. It's not every cycle, but there could be some surveillance done with that. But we'd also have to have some agreement on what would we use for cutoffs based on percent body fat, let's say, to look at changes over time. I mean, you can look at means. There are different ways to do it, but I think it is a challenge because of the simplicity and the inexpensive nature of BMI and being able to, you know, that it is really useful for that. But something like NHANES, you could do some other types of surveillance with other methods, just not in all surveillance systems.
Thank you, Dr. Ogden. Dr. Ard, so assuming BMI is not going anywhere for a while, how could we use it to greater effect in the clinical setting? So are there some simple things that could be done now to improve on its usefulness?
So I'll go back to one point I tried to make is I do think that the trajectory of weight is an important metric to integrate into BMI. I've can tell anecdotes of patients who we've treated and they've been very successful. They go back to their primary care provider after a year of treatment and they've reduced their weight significantly, and the primary care provider doesn't notice that, and they just look at the BMI and say, well, you should lose some weight. And it's sort of like, okay, well, let's just pay attention and do something that's really kind of practical. So every electronic health record could say, here's the change in weight since the last time this patient was seen in this setting. So I think that could be helpful. I think we could also further integrate electronic health records to bring some of the additional information together. So as we've said, BMI is a screening tool, but there are other pieces of information that could be useful to bring along with that, like say an ASCVD score, your risk for cardiovascular disease over the next 10 years. And, does this patient have risk for sleep apnea based on some questionnaire, for example? What is their family history? What are the social determinants of health? All of that is available in an electronic health record. And the benefit theoretically of an EHR is that it should make synthesizing that data a little bit more easy for the clinician. And I think that might move us, beyond just, well, here's what that number is. I think this is what that means. And then, a rote knee-jerk response.
Ms. Wright, thank you for, again, sharing your personal story. And I think that for many of our patients, some of the terms you use, like physically healthy or normal range or normal weight, right, can be a moving target, if you will. And we've talked about the challenges when we're just looking at a number on the scale. So just from your perspective, as we have these discussions, how can we do a better job of educating our community members on what obesity is and what that is versus other terminology? I think as clinicians, in my perspective, I can tell you the 5, 6, 7 factors that I'm considering to see if someone's level of adiposity is related to a poor health outcome, but that can be difficult to explain to a patient versus a number on the scale. So any comments on that?
Yeah, I definitely think it's difficult to explain some of these terms because coming as a patient myself, we may not know what these things mean, but I think it also takes patience from the provider to explain the significance or what this actually means and how that will impact your health. Also, I think it's important to spend time with the patient. And I know coming from a patient's perspective, we don't feel that we have the knowledge or the words, or we're afraid or intimidated by medical providers because we feel like we may not be understood or heard from the provider, and maybe we'll be intimidated because they have more knowledge or more education than us. But I think if we also explain things on a patient level, that those things will be more helpful. And I think also just changing the language around using terms like overweight or fat or obesity. I think it depends on the patient themselves and their experiences on maybe things that have been traumatic for them and what they feel is most comfortable. So it's definitely a dialogue between patient, and it's definitely an individualized experience.
Thank you. I know we're running low on time, but if we have any questions from the roundtable members that are here present, you can click your mic and just state your name. Or any thoughts or comments. Also looking online and there are any comments in the chat box. Please go ahead.
Thank you all very much. This was an excellent panel. Jamie, maybe this is best directed toward you, but hearing a lot about the individual care and the time that needs to be spent and the dialogue and what healthcare providers really need to make a difference here. Could you comment on structurally what that will take within either training or the healthcare system to enable these interactions to be more positive and holistic?
So the short version is we need to just change our healthcare system. It's really just not suited to allow for the things that she mentioned there in terms of the time and the patience and the ability to integrate data and to understand people over time in their context. And so we work in a specialized setting in our center, and we have some of that luxury, but it is awfully challenging even with all of the resources that we have. And so I have a lot of empathy for frontline practitioners who don't have the training or the resources that we have, nor the time. And they are challenged with trying to implement treatment or talk to patients to educate them in that space. And I think our incentives within our health system are just completely misaligned to really sort of drive improvements in health. We don't pay providers, practitioners to improve health. We pay them to see more patients.
All right, I think we're coming up to the end. I see a couple of questions. So I'm looking at our team to see if we can take one or two. Okay, let's take one. So there's a question with regard to BMI as a screening tool. Should it be, if we understand it as more of a screening tool, should it continue to be a threshold for treatment modalities like drugs or surgery?
Yeah, so I think in that line of logic, it should not be, and we should allow clinicians to then have their medical judgment in order to be able to understand what the treatment modality and the indications should be. But I also understand the practical issues of cost and the way the drive for thinness is in our society, and understand that opens up a can of worms when you think about you could have this treatment available for anyone who could afford to pay for it. And you know, that creates some ethical challenges, I think, as well as some resource challenges and so forth. So yes, I would say we would like to have more leeway, but can understand how we got to the point that we are now.
Thank you. I think we're up on time. So thank you to our audience. Thank you to our speakers, our panelists who are here and joining virtually. This is Dr. R, Dr. Ogden, and Ms. Wright. We are now at our lunch break, and we will return at 12:45 p.m. in this room, and lunch is served outside. Thank you.